Hi, and welcome to today's lecture on coarctation of the aorta, which is a congenital heart defect that narrows one of the body's lifelines, the aorta, and jeopardizing the efficient flow of blood. If you want to stay informed, then join me and let's unravel the tales of this condition together. Alright, so coarctation of the aorta is simply a congenital heart defect which is characterized by narrowing of the aorta, as you can see right there. And this typically occurs in the thoracic region, just distal to the left subclavian artery. Very rarely, coarctations may also affect the lower thoracic or abdominal aorta. For simplicity's sake, we're going to divide or delineate this diagram into two sections. That is a proximal section, which spans all the way from where the defect is and goes all the way into the left ventricle. This section is subject to extremely high pressures, robust perfusion, and strong pulses. This is very important, and this occurs as a result of the impedance or the resistance or the narrowed constricted area in the aorta. Now, the distal part, which goes below the defect, is characterized by very low blood pressures, low perfusion, and very low pulses to even absence of pulses. Let's try to take a closer look at what happens in the proximal section, okay, starting from the left ventricle and progress further in that manner. We can see that the left ventricle must do exceptionally hard work to push the blood through this narrowed section. And so that work that is being done by the left ventricle can actually be expressed as afterload. So the afterload is very high, and this predisposes to hypertrophy of the left ventricle, which can cause left ventricular failure eventually and a congestive heart failure. Okay, now the enlargement of the left ventricles can also predispose to mitral valve regurgitation, and this in fact can also cause endocarditis in general. Let's proceed to what happens in the aorta. As we are saying, the proximal part is exhibiting high blood pressures. These pressures is also transmitted to the walls of the aorta. And so that heightened pressure in the aorta poses a risk of aneurysm formation, which may lead to potentially life-threatening complications like rupture of aneurysm or even aortic dissection. Furthermore, looking into the intricate anatomy of blood circulation in the proximal section, we see that blood goes into the brain from this part, blood goes into the arms, okay, from the subclavian arteries, and also blood goes into the chest as well. Now, if this part is exhibiting extremely high blood pressures, then what can happen is that patients may complain of, for example, signs of transient ischemic attacks. There is a risk for strokes. Okay, there can even be nose bleeding, chest pain, endocarditis, dizziness, or even headaches. This is the basis for the clinical manifestation, and that is because of the extreme high blood pressures in this area. Now, the critical aspect is also the patency of this structure we find here, which is the ductus arteriosus. Ductus arteriosus closes functionally within 24 hours after birth, and it permanently closes around 2 to 3 weeks, after birth. And so, just imagine blood going through this narrowed section. There is a resistance, and so some of the blood will go into the ductus, and so it relieves the proximal section of some of the pressures and relieves the symptoms. Now, as soon as this part closes, this can lead to clinical manifestations of acute heart failure and signs of shock. Okay, so this is very important to note. Now, in contrast, the distal parts, as we said right here, okay, the distal parts of the circulation also experiences a reduced pressure and perfusion. And so this may result in renal insufficiency. You remember that the kidneys are right in the abdomen, the intestines are also there. They can all suffer ischemia, right? There can also be a lower extremity claudication, which is pain on movement or during exercise or walking, for example. And signs of ischemia such as cold extremities may also be seen. So a careful assessment of the pulses, particularly by noting any radial femoral delay, is very important because the pulses in the lower extremities are low, okay, and the pulses in the upper extremities are high. And so when you notice this, then the threshold for suspecting coarctation of the aorta must actually be reduced. So, all right, so once again, in coarctation, we said that there is a proximal section, right, that experiences hypertension, and the distal, which experiences low blood pressures. So there is actually a pressure gradient existing between these two parts. And this pressure gradient stimulates the development of collateral circulation to the abdomen as well as the lower extremities. So, for example, blood is not able to move freely across the narrowed segment, right? And so blood may return, for example, into the subclavian artery and then through the internal thoracic artery, which we find right there. You can also see it right here. From there, blood may enter the intercostal arteries and also through the internal mammary artery and the scapular arteries. This is just an adaptive response that facilitates blood flow into the regions that are affected by the reduced aortic pressure. Okay, so as the intercostal arteries become hypertrophy or say dilated, it's because it is not able to accommodate this increased demand anymore. They can occasionally erode, as you can see, the third to the eighth rib, and this leads to this characteristic rib notching, as you can see right there. Okay, this is appreciated on a chest x-ray, a rib notching on the third to the eighth rib. Again, on a chest x-ray, you might also appreciate the figure of three sign, which is just the shadow of the coarctation. So it may be something like that, okay, which is referred to as the figure of three sign. On auscultation, there may be an ejection systolic murmur at the upper left sternal border as well as the left interscapular region. In cases of severe coarctation, this may actually evolve into a continuous murmur from collateral circulation, particularly in the intercostal spaces. Additionally, it is important to note that the most prevalent valvular anomaly linked with this condition is a bicuspid aortic valve. Now, in the evaluation of coarctation of the aorta, electrocardiography may reveal signs of a left or a right ventricular hypertrophy, reflecting the condition's severity. Echocardiography, whether through a transthoracic or a transesophageal methods, still plays a pivotal role in assessing the anatomical as well as the functional aspects of the heart, while the Doppler velocity measurement can also effectively help determine the pressure gradient across the coarctation. Although not consistently observed, chest x-rays may also show a characteristic rib notching along the inferior borders of the third to the eighth ribs, and the classic figure of three sign may also be seen on a chest x-ray. Additionally, advanced imaging techniques such as contrast-enhanced CT, MRI, and cardiac catheterization also offer valuable insights in enhancing the overall assessment as well as the management of this condition. So the treatment of coarctation of the aorta is tailored to the severity of the condition with surgical interventions like coarctectomy, that is resection of the coarctation. This is often preferred in childhood for optimal outcomes. Alternatively, balloon angioplasty with or without stenting may also be utilized with the choice of modality frequently influenced by the capabilities of the surgical institution performing the surgery. Medications such as prostaglandin E1 can also help maintain a patent ductus arteriosus, while beta blockers, ACE inhibitors, ARBs may also offer some symptomatic relief. However, it is crucial to be aware that hypertension can persist for years following surgical repair, necessitating ongoing management and monitoring. Thank you, and I hope this was useful. If you enjoyed it, then hit the like button and subscribe to the channel. Bye.